Hi, my name is Gino Stefano Yanqui Saltos, and today I'm going to talk about lenvatinib versus placebo in radioiodine refractory thyroid cancer. Definition: lenvatinib is an oral multi-targeted tyrosine kinase inhibitor of the VEGFRs 1, 2, and 3. The purpose of this study of lenvatinib in differentiated cancer of the thyroid is to assess progression-free survival among patients with iodine 131 refractory thyroid cancer who received lenvatinib as compared with those who received a placebo.
Future now of the thyroid cancer trials is going to be a combination. Can we put them together? Can we do it in a way that is not going to have too much toxicity? And actually, can we maybe start to get more evidence of improved overall survival and also even maybe some cures if we do it in the earlier setting? So there are trials right now going forward with lenvatinib where we're combining with everolimus. There's another trial with lenvatinib where it's combined with pembrolizumab. There are going to be additional, I think, combination therapies possibly between agents, maybe even between kinase inhibitors.
Applications in medical English. Thyroid cancer that is refractory to radioiodine or iodine 131 therapy is 10% from the time of detection of metastasis. Although treatment options have historically been limited, efforts have first targeted vascular endothelial growth factor VEGF and its receptor VEGFR. Because of the involvement of these multiple pathways, multi-targeted tyrosine kinase inhibitors are being investigated for the treatment of thyroid cancer that is refractory to iodine 131. The pros and cons of the lenvatinib. 64.8% in the lenvatinib group showed a positive response against 1.5% in the placebo group. As to complete responses occurred in 4 patients in the lenvatinib group as compared with no patients at all in the placebo group. As to partial responses occurred in 165 patients and just 2 patients that received a placebo.
And I think that this is a job for a specialist. I think to introduce a drug like this in the community where you see 1 or 2 patients per year with a disease release, that's too early. I think the handling of the toxicity, dose reduction still needs to be in a centralized fashion. And then it can expand later on when it's more developed. I think it's too early to let go to everybody. I think you should keep it on few hands. In my country, for instance, all thyroid cancer patients are treated with me only, meaning that I take care of 6 million inhabitants. So they are referred to me only because we need this centralized evaluation of these patients.
As to the issue applied in Ecuador, I didn't find any relevant information as to lenvatinib that was used here in Ecuador.
So this was a subgroup analysis that was based off of the large phase 3 SELECT trial, which was the large randomized clinical trial between lenvatinib and placebo in patients with metastatic radioactive iodine refractory thyroid cancer. This particular subgroup analysis was looking at differences in clinical benefit, meaning overall response rate and progression-free survival in patients who had previously been treated with an anti-VEGF therapy versus those who had not had any prior therapy. In essence, the subgroup analysis, which was led by Dr. Kate Newbold, shows that whether patients were previously treated with an anti-VEGF therapy or were naive to therapy with an anti-VEGF type of tyrosine kinase inhibitor, the clinical benefit was similar in terms of overall response rate and in progression-free survival.
As to the conclusions, lenvatinib, as compared with placebo, was associated with significant improvements in progression-free survival and the response rate among patients with iodine 131 refractory thyroid cancer. Patients who received lenvatinib had more adverse effects, although. Thank you very much.